Okay, let's go ahead and get started. So good afternoon, everyone. Happy Friday and a very happy new year. I hope everyone's doing well today. Thank you so much for taking time out to join our echo session today. Before we get started, can I please have everyone take a minute to set their Zoom name as their first and last name, as this helps me with identifying who is on. Thank you. Next slide, please. So if this is not your first echo session with us, then this will look familiar. However, this is the structure of all of our echo sessions, starting with announcements and introductions, followed by a didactic session, in which today's topic will be focusing on disclosing and confirming the diagnosis. We will then be moving on into our collaborative case discussion, followed by closing and reminders. Next slide, please. So to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. Please always introduce yourself with your name and location prior to speaking. Maintain confidentiality when speaking about your clients. And please refrain from using any identifying information, and please respect others and their opinions. Next slide, please. So we are CME accredited. Our main objective is to empower providers to feel capable and comfortable with the assessment and care planning for dementia and to expand access to geriatric specialty care throughout California and beyond. So today's session is accredited for 1 CME credit. Certificates will be sent out by our CME office at the end of each month and will outline the total number of hours you attended. And many other licensing boards, like the California Board of Nursing, also recognize the CME for reciprocity. Next slide, please. So our series is a part of HCBS Dementia Care Aware Award, which is supported by the California Department of Healthcare Services. One of the main goals for our grant is to create a dementia-friendly California for the population in need of equitable and excellent care, which is the older adults, and also to train geriatric specialists, primary care providers, and health professions, trainees, and help expand our geriatrics workforce. Next slide, please. So I would like for everyone to take time to quickly introduce themselves on video, but since we have quite a few individuals on the line, which is wonderful, we'll go ahead and have everyone introduce themselves via the chat function if you can. When doing so, please list your name, role, site, and location. Next slide, please. So in the meantime, we'll go ahead and have our hub team introduce themselves on video so you can get to know us, and I'll get us started. My name is Manahil Khan, and I'm the project manager for our Dementia Care Aware project at UC Irvine Health, and we are located in Orange, California. Dr. Segla, if you want to go ahead and introduce yourself.
Sure. Thank you, Manahil. My name is Sonia Sagal, and I am a clinical professor here at UC Irvine and geriatrician at our Senior Health Center in Orange, California.
Thank you, Dr. Sagal. Next slide, please. So Dr. Sagal is our presenter today. So Dr. Sagal, the floor is yours.
Thank you so much. Thank you, everyone, for joining us today. It's really my pleasure to be here to chat about cognitive impairment. And today we're going to move in and talk about an approach to confirming the diagnosis. If you are familiar with and have taken the Dementia Care Aware training, you'll know that the program is focused on screening for cognitive impairment. And you might be wondering, well, what do I do next? So if a patient screens positive for cognitive impairment or shares with you their concern about cognitive impairment, today we'll outline some steps that you can take to move the patient through the process of confirming a diagnosis. So on our agenda for today, I'd like to preface this talk with some information about what's happening in America and in Orange County, where I'm located. And those statistics are probably similar to where you are. I'll introduce or reintroduce the DCA, the Dementia Care Aware California program. And then we'll talk about a plan for a workup for cognitive impairment. And then we'll briefly touch on considerations for disclosing the diagnosis. Again, we're very thankful for you, your time joining our echo session today. As I mentioned, we'll be talking about diagnosis today and confirming the diagnosis, but in subsequent sessions, we'll talk much more about management, both pharmacologic and non-pharmacologic. So although I'm not touching on those subjects today, our subsequent sessions will be focused on those. So let's put this in context, and I don't think this information here in the next few slides will be surprising to anyone. But in my area, in Orange County, by 2040, almost 1 in 4 people will be older than 65. And I'm sure that that is a trend that you are all seeing in your clinical practices as well. The more and more of your patients in primary care are over 65, or certainly within that geriatric age group. Here in Orange County, a few years ago, there was a look at our population. And this figure here shows the projected population growth increase over time. And you can see that the different colored lines represent different age groups. And the line that I've circled here in red, which is the orange bar with the uptrending line, which is the only one that's showing growth, really is that age group over 65. So again, we will be caring for and managing older adults in our practice. And if anyone feels like they're isolated and the trends don't look like that in their area, I wanted to share this infographic from the United States Census Bureau, which actually shows that for the first time in US history, older adults are projected to outnumber children by 2035. So the growth in our older adult population certainly is incredible. And because of that, we all need to be prepared to manage the healthcare concerns that become more common as we age. And of course, cognitive impairment is one of them. Now, if you, think about cognitive impairment in your practice, as I certainly do, anytime I see a patient over the age of 80, I like to remind myself of the information presented in this Archives of Neurology article. And this is, several years old now, but it's just a rough reminder for me that for people who are over the age of 85, the prevalence in that age group of cognitive impairment or Alzheimer's disease, looking based on this presentation, approaches 50%. So the way I think about this is if I have 2 or 3 patients on my panel for a day that are over the age of 85, probably one of them has some sort of pathologic cognitive impairment that I need to screen and assess. Again, this is just a rough estimate of prevalence, but it's just a number that's easy for me to have in my mind. So again, based on that Archives of Neurology present article, the prevalence is 50%. For people over the age of 85 who have some kind of pathologic cognitive impairment. And an earlier article presented by Callahan stated that far fewer people were actually recognized and were diagnosed with that kind of pathologic cognitive impairment. So his study showed that dementia was recorded as a diagnosis for less than 25% of patients with moderate to severe impairment. So these are people that would have obvious deficits on examination or interview. And in a previous echo session, we talked about the importance of early identification of cognitive impairment for people, really to be able to provide meaningful care, whole person care, and really to identify what matters most to the individual. So I think it is very important to think about screening, identifying, and managing cognitive impairment in our primary care practices. I realize that that statement comes with a great deal of challenge. It's time consuming. It is intense to manage patients with cognitive impairment, but it's also very rewarding. And I feel very thankful that in the state of California, under the guidance of Anna Chodos and Dr. Josette Rivera, that we have the Dementia Care Aware program and that the state has set aside funds for us to train and to manage these patients. So I'm hoping that you all are familiar with the Dementia Care Aware project. And this was a benefit that was passed, I believe, in 2021. And it allows for training for primary care providers of Medi-Cal only beneficiaries, 65 years of age and older, for a cognitive health assessment and plan. And for primary care providers that go through the training, they are able to bill Medi-Cal directly for their services. Now, for those of you who have not gone through the training, please do take a moment and go to dementiacareaware.org, where you can sign up, go through the training, and avail yourself of all of the resources available. The training will walk you through the 3-step cognitive health assessment. And this is a very useful tool that I'm going to dive into in some detail in just a bit. But the training will walk you through taking a patient history, using tools such as a mini cog to assess cognitive and functional decline. So you'll assess both cognition, you'll screen for cognitive impairment as well as functional decline, and then you'll establish and document a patient support person or healthcare agent. And just as a reminder, the definition of dementia is acquired cognitive decline, acquired functional decline, and that is not related to any other cause. And we'll go through that in a little bit more detail in just a bit. Okay, so as a reminder, the training will walk you through a toolkit, a toolbox. You'll learn about different modalities to screen for cognitive impairment and assess function as well. Okay, and then again, as a reminder, you do have the opportunity to bill for services. But let's say you go through the training, as many of you have, I hope, and you start to use a 3-step process to screen for cognitive impairment. So you see a patient, you recognize that they have some cognitive complaint, you use your tools, you assess function, you use one of the screening, cognitive screening modalities, and you establish a support person. What do you do next? So let's talk about that in some detail. So we'll use a few cases to get us started, okay? So in a previous session, I presented a case of a woman who was 76 years old, and she came in with her daughter and her son. She had a past medical history of osteoarthritis and hypertension, and she presented with a 2-year history of slow and progressive short-term memory loss. Her family shared that she was forgetting to take medications consistently, but she was about 90% accurate. She was forgetting details of medical visits, social events. She was vague with responses, and she, although had never been good with details and had no medical background, there was some slippage that her family had noted. She was able to perform her activities of daily living without assistance, and she was independent with IADLs as per the family. And her family thought that her cognitive changes were consistent with a normal aging process. So using the DCA framework, step 1, to take the history, we did that. I presented some of the details for you in the previous slide. You can use your tools to assess cognition and function. So in this patient, we performed the mini cog, which you'll recall is a 3-item recall and clock draw. And she scored 0 out of 3. On ADLs and IADLs, we assessed this briefly as part of her history, and they were as noted prior. And her son and daughter were agreeable to be her support folks. But what do we do after that? So what would we do next in order to best manage this patient? So that's case number 1. Case number 2 is a little bit different, and I'll present this, and I'd like you to think about both of these cases as I move through. So case number 2, this is a 76-year-old female who came in to the clinic alone. Her past medical history was significant for diabetes and hypertension, and she had a subjective complaint of memory impairment. She herself was worried about it. She lived alone, she was managing her bills, her finances, and had no issues, no lapses. She told us that she was forgetting details of conversations and sometimes found it difficult to remember the names of people that she had just met. She was performing her ADLs and IADLs without assistance. She was concerned about some mild word finding difficulty, and she noted that her husband had died 2 years ago of COVID-19. We used the DCA framework for her, and her history was as presented, and her mini cog was a 3 out of 3. And she was independent with her instrumental activities of daily living, as well as her activities of daily living. Her issue was she had no support person and could not identify anyone for us. and she lived alone. So you can see that these two 76-year-old patients are very different in their presentation and will likely require a very different form of management, but need to be managed nonetheless. So let's talk through how we would go through and manage these folks. Okay, so before we talk about management, we should talk about the differential diagnosis of cognitive impairment. Both of these individuals had some degree, they had memory issues. One had a memory complaint, the other not so much. So one lacked awareness, one had an awareness of her memory lapses. And the history definitely plays into our identification of the ultimate diagnosis. But the differential here for cognitive impairment is vast, it's broad. Some issues include neurodegenerative disorders. We've talked about those in previous sessions. So those would be things like Alzheimer's dementia, vascular dementia, FTD, so frontotemporal dementia, or Lewy body dementia. And then there are a whole host of other causes of cognitive issues, which I'm sure you're all familiar with. As a reminder, thyroid disease, so hypothyroidism, vitamin B12 deficiency, are two reversible forms of complaint that can cause cognitive issues. Certainly depression, normal pressure hydrocephalus, sleep apnea, alcohol or substance use issues, HIV, neurosyphilis can contribute to cognitive issue, and medications. So we'll talk about some of these in detail. And as you can imagine, all of these medical issues can present slightly differently in our patient. So when we think about making the diagnosis, I think it's important to remember that dementia is a syndrome. There is not one particular lab value, imaging modality, a physical exam finding that will give us 100% confirmation that someone has a dementia. This is a syndrome. And it's important to remember that of the analysis that takes place to diagnose someone's cognitive impairment, the medical history is probably the most important. So we really spend a lot of time taking a medical history. We follow that up with a physical exam focused on the nervous system. So looking at the neurological exam, also with a focus on hearing and vision. So sensation is extraordinarily important. And for people that can't hear or don't hear well, they cannot consolidate information, they can't hear it, so they can't consolidate it, and certainly vision impairment as well. We follow the complete H&P with a cognitive evaluation, and if you've gone through the DCA 3-step process, you may have already done that. Maybe you completed the mini-cog or another screening modality. We follow that with a medication review, an assessment of conditions that might mimic dementia. So we want to make sure that we've ruled out delirium and or depression. We follow that with laboratory testing. We think about brain imaging, but often do not need it. And we think about our differential diagnosis again. So let's do a little bit of a deeper dive here. So when we think about the medical history as it relates to cognitive impairment, one of my colleagues shared with me this mnemonic, NW-COMS. So we think about the nature of the complaint. So are they forgetting appointments? Are they getting lost? Are they misplacing things? Are they having difficulty with word finding? Are they missing like bills or payments? Are they going in late? Do they have language issues? Any behavior changes? Are they hallucinating, agitated, or depressed? I had a patient, a very dear patient of mine, who was very young. She was in her late 50s, who was doing well and working. And the first sign that she had a neurodegenerative condition was that she forgot to pay her bills consistently. And she was taking them to the post office, but she would actually forget to go to the post office, and her husband found a large stack of bills that were unpaid over several months in her car, and she had just forgotten to process them. We think about the when. So what Is this occurring over days, months, years, or decades? The course, so is it abrupt in onset? Is it a stepwise, progressive decline, slow? What does that look like? We always talk about function and we assess function. So function in compared to one's baseline. So what are or if any, are there changes? So, and that's important because patients can have cognitive changes. They can have memory impairment, but still be functional. And if they're not, then we start to think more about a neurodegenerative condition. We think about their living situation. Are they grieving? Have they experienced loss? Who's in the home with them? Is it a tense situation at home? Is it a soothing situation? Are they alone? Have they recently moved? We think about mood and all of the symptoms of depression that go with it. And we ask about their health status. So things like thyroid, delirium, electrolytes, and whatnot. Now, this is a large list of questions to ask. And if you are on an electronic health record like I am, you can certainly format this into a smart phrase or format a progress note to have all of these questions there that you then go through and ask your patient. And it certainly does save time to do it that way. And actually, one of my fellows has a lovely template that incorporates all of the cognitive history. So in addition to what I would call the past, the history of present illness, we also look at past medical history. So as you know, conditions like diabetes, hypertension, stroke might make someone vulnerable to vascular insult. Certainly head trauma, brain injury, or surgery. So if they've had recent surgery or recent hospitalization for an infection, maybe their abrupt onset of cognitive changes is related more to delirium than an actual dementia or neurodegenerative condition. We look at family history of dementia. We assess medications, and then of course, social history, and with an eye on driving and living arrangements, and then of course, a review of systems. And the review of systems for me focuses on things that might clue me into a particular etiology of the cognitive change. So are they having gait issues, balance issues? Are they falling? Have they developed a tremor, new incontinence, weight loss, headache, blurry vision, some weakness that's asymmetric, mood issues, insomnia, rash. Okay. So again, I think in an effort to be efficient, really thinking about incorporating those things into a template in your electronic health record is really important. In terms of the physical exam, we do a complete physical examination, looking in particular at the neuro exam. And we try to observe for things like tremor. So are there other involuntary movements or tremor? Do they have fluid speech? Are they obviously having issues with word finding? What does their facial expression look like? And are they disinhibited? We've had interesting patients come into the office. Some are hypersexual. Some can be very in your face and very direct about what they're thinking. And if it's out of character for them in their life and what they've been like, it does give us an idea of some disinhibition. We watch people walk and assess their fall risk. And if someone has a tremor that's relatively new, maybe they have a shuffling gait, maybe their facial expression is flat, you start thinking about a condition like Parkinson's, or they might have Parkinsonian features with associated cognitive changes. If they have issues with eye movement or visual field abnormalities, maybe you're thinking about a more rare form of a neuro condition that can be associated with cognitive impairment like PSP. Stroke patients who are at risk for vascular disease often have asymmetrical deficits noted on neuro exam. Cogwheeling or neuropathy. The neuropathy might make you think of a vitamin B12 deficiency, for example, leading to cognitive impairment. So the neuro exam is really important. It's important if there are findings, and it's important if there are no findings and the patient has a completely normal neuro exam. This will guide our decision on whether to image or not. I think most primary care providers are pretty comfortable ordering labs to assess for cognitive impairment. The American Academy of Neurology recommends checking a CBC and a vitamin B12 level. And the reason for the vitamin B12 and thyroid, of course, is to look for potential reversible causes of cognitive impairment. Some folks will order an RPR to assess for neurosyphilis. In general, in our practice, we do not order that on every patient. We do order it for folks who have high-risk behaviors in their past, and if the past medical history warrants that lab test. And then, of course, a urinalysis, maybe, if there is a medical need for that. But in general, a CBC, a TSH, vitamin B12 are very helpful. In regard to imaging, so if a patient has a very classic presentation of Alzheimer's, so they have a slow and progressive cognitive decline over the course of a few years, and they have a normal neurological examination, so they're not lateralizing in any fashion, maybe you forego imaging a CT or MRI as the yield might be low. And we don't generally order imaging in those patients, but if the patient has some red flag findings, so there are maybe a rapidly progressing presentation, early onset, younger than the age of 65, head trauma, malignancy, if you're worried about a space-occupying lesion, for example, or if you're concerned that they might have normal pressure hydrocephalus, so maybe they're coming in with cognitive decline, a gait abnormality, and some new onset urinary changes, maybe in those patients, you consider getting a CT or MRI. But in general, for the classic patient with Alzheimer's, we generally do not feel the need to image. So the neuro exam really does guide your decision-making there. So again, I just want to highlight the importance of the medical history and physical examination. As part of the initial assessment, you will have completed a cognitive evaluation, so whether that's a mini-cog or other exam. And I just wanted to remind you that you have several options with which to screen for cognitive changes, right? We're all familiar with the MMSE, so the Mini Mental Status Exam. There is the MoCA, or the Montreal Cognitive Assessment, and then of course the mini-cog. Personally, in a busy clinical practice, I like the mini-cog. It's quick, it takes about 3 minutes. It's the clock draw and 3-item recall. And for patients who may demonstrate some sort of cognitive issue and decline in their mini-cog is abnormal, I might consider on a subsequent visit administering a mini mental status exam or a MoCA, just to give me a little more information. And this is what the MoCA looks like. If you're not familiar with it, it does take about 20 minutes to administer. And it's important that you follow the absolute instructions on how to administer the exam. There's actually verbiage that you will read aloud to your patient to have them complete the test, but it does give you much more information. I wanted to also call your attention to the SLUMS. So the SLUMS is another cognitive screening tool, and it has been translated into many different languages. So if you're caring for a population that is not native English speaking, there are lots of options here with the SLUMS examination. So again, cognitive screening, I think the mini-cog is quick and efficient and can definitely give you an idea of cognitive changes or decline in a patient. And if the patient has cognitive changes by history, but maybe they have a normal mini-cog, maybe you choose to bring them back in 3 to 6 months and then re-administer the examination, or you re-administer a MoCA or a SLUMS, and you track change over time. I think it's incredibly important to administer these tests, at 6-month intervals so that you can objectively track cognitive changes as they are occurring in your patient. Now, what about formal neuropsychological testing? So there is a place for formal neuropsychological testing. In my office, we are extraordinarily fortunate to have 2 neuropsychologists, but the testing is pretty detailed, and it's labor intense, and it's long, and it's hard for patients to do. It takes between 1 and 3 hours. It can be very taxing. And I think it's a wonderful tool to establish a baseline for patients who have very early cognitive changes, and it might help in those situations to differentiate the type of neurodegenerative change going on. I think in patients who are highly educated, who might do very well on a screening assessment, but are experiencing cognitive changes, and there's some discordance there between testing and history. I think it could be very helpful in those situations, especially when someone is very highly educated or high functioning. And in patients who have some degree of depression, anxiety, or mental health issue that might be clouding the picture, I think it can be helpful to tease those aspects apart. Now, let's talk a little bit about medications. I think our next echo session in a week is focused on medications that impact cognition. But I did want to put a reminder here that anticholinergic medications like diphenhydramine, hydroxyzine, really these PM medications that patients have access to at their pharmacy can be very, very, very devastating for patients who have a mild degree of cognitive decline. It can certainly make that look worse. I have had patients come in to see me, and they've been on 50 milligrams of diphenhydramine nightly, and they come in and they look like they have a mild dementia. And they test poorly. They feel physically unwell, and they are aware of their cognitive deficits. They don't really understand why. And simply withdrawing the diphenhydramine brings these folks back to their cognitive baseline. Benzodiazepines, of course, can negatively impact cognition, sleep aids, and muscle relaxants. There are a whole host of other medications that can negatively impact cognition that we'll review in our next session. So we've talked about a number of things that need to be assessed when making the diagnosis of one's cognitive impairment. So we've talked about the medical history and physical exam. We've talked about serially administering a tool to assess cognition. So whether that be the MoCA, the SLUMS, or the mini-cog. We've talked about a detailed medication review. And we've talked briefly about delirium and depression, laboratory testing, the plus or minus need for brain imaging, and an assessment for reversible causes. Now, I wanted to just say a few words about each of these before we move on. So obviously, if you have someone coming in with cognitive complaint and you go through these steps and you find that they have a deficiency of vitamin B12, you replete the vitamin B12, and then you re-administer your cognitive tool, and you re-evaluate them, and hopefully their symptoms have gotten better. Maybe someone comes in and they've had a very significant UTI, they were hospitalized for pneumonia, they had influenza. Subsequent to that, they've had some cognitive changes. You give them some opportunity for their delirium to resolve, and then you reevaluate their cognitive status. So the serial evaluation of some of these conditions is very important. I actually had a patient in December of 2021 develop COVID-19 and influenza concurrently. He had a delirium that lasted 6 months, and it slowly lifted. And he was significantly impaired initially, but slowly he returned to baseline. So these things can take some time to come to resolution. This is a framework that was developed by one of my colleagues, Dr. Stephen Tam, as a methodology for the workup and management of memory loss. And it's a nice tool, and I'll walk you through it. It just kind of reframes the workup in a way that is just really easy to follow. So if a patient comes in with memory complaint here at the top, you start off with your history and physical, with a particular eye on disease course and function, looking at medications, family history, social history, the exam, and you perform your cognitive screening assessment, your tool. You administer the cognitive tool. You follow that up with labs to look for areas that might be reversible or might be contributing to cognitive decline. And then you think about imaging, right? If you suspect the patient may have had a stroke, or some structural issues, maybe you administer a CT or an MRI. You assess for the reversible causes, so metabolic disturbances, endocrine, infection, alcohol, drugs. You assess sleep, depression, anxiety, and other psychiatric issues. And then depending on what you find, you can categorize the individual as having either normal memory with changes consistent with aging, a mild cognitive impairment, or a dementia. And remember that for a dementia to be diagnosed, there has to be a cognitive change from baseline, a decrease in one's ability to function, and it shouldn't be related to any other medical etiology. Now, if someone is found to have normal memory changes consistent with aging, you reassure them. You encourage them to stay active, you monitor and follow up. If someone does have some slight deficit in cognition and they're found to have a reversible cause related to it, or some kind of mild cognitive impairment, you treat the condition, you encourage them to stay active, you monitor and follow up. And then of course, if they have a more significant impairment, you consistent with a major cognitive disorder or dementia, you treat the medical conditions, you treat the dementia, and you follow up. And you can treat obviously with non-pharmacological methods or pharmacological methods, and you address caregiver and lifestyle. And all of these will be discussed in a subsequent session. Now you might be wondering, when should we consider a referral to neurology or geriatrics or or psychiatry in the management of these patients? So if you find that you have a patient with a rapidly progressing cognitive decline, or if the individual is very young, say younger than 60 or certainly 65, or they have atypical features, or an atypical or an unusual abnormal neurological exam, maybe you refer those folks on to geriatrics or neurology. But for the most part, I think it's okay to manage and serially follow up and see how patients progress over time. So let's go back to our case presentation. So we had our first case one, which was a 76-year-old patient who had a son and daughter with her past medical history of osteoarthritis and hypertension, who came in with a 2-year history of slow and progressive short-term memory loss. She was forgetting to take medications. She was forgetting details of her medical visits. She was, although she was able to perform her ADLs, and you did your cognitive health assessment, and you found that she had a 0 out of 3 on her mini cog, and her son and daughter were her support people. So maybe in the chat, tell me what you feel might be happening with this lady and where you'd like to go with her care. Does anyone have any thoughts about that?
Again, please feel free to unmute yourself or put answers in the chat.
So I can walk you through this one. So our patient came in. She was brought in by her son and daughter, and she was forgetting to take medications, and they had noticed a slow and progressive decline. So in terms of her history, we did the history. It showed that her course was, we talked about her course. She had no offending medications. She had no family history that was significant, no head injury, and she had really good social support. Her son and daughter were there to care for her and support her. She scored 0 out of 3 on the mini cog, so she was obviously impaired. Her labs were all normal, so she did not show any issue metabolically. And because her neurological exam was normal and her disease course was slow, and she was not under the age of 65 or very young and did not have an atypical presentation, we opted to forgo imaging for her. She had no issues with sleep. She was not depressed. We actually administered the PHQ-2 to assess that. And we found that we actually initially diagnosed her with mild cognitive changes. And at a 6-month follow-up, her function had significantly declined. And she was then diagnosed with probable Alzheimer's dementia based on her medical history and her physical examination. And we followed her up with the initiation of donepezil and ultimately memantine, and we continued to follow her care at 3 to 6 month intervals. For our second patient, this was a 76-year-old female that had a history of diabetes and hypertension and a subjective complaint of memory issues. When I see the past medical history of diabetes and hypertension, I immediately think of vascular risk factors. And so that's sort of in my mind. She was living alone. She was managing okay, but had lost her husband recently. And obviously we're concerned for some degree of grieving, bereavement, depression in this individual. So for her, if you recall, she scored 2 out of 3 on her mini cog, and her ADLs and IADLs, she was independent. She had no support person. So as we worked with her through this algorithm, we assessed her cognitive complaints. They were subjective, not corroborated by findings on her ADLs or her IADLs. She did miss 1 point on the mini cog, and the point that she missed was in her clock draw. So she was able to recall the 3 items. She had no abnormalities in her blood work. She did not lateralize on her neuro exam, so we opted not to image her. She was fully functional, so we did not diagnose her with a dementia. We thought that, but she also was not quite normal. We diagnosed her with mild cognitive impairment, but we actually, on further evaluation, administered the PHQ-2 and found that she was depressed, and diagnosed her with depression with cognitive changes. We treated her with an SSRI, and we asked her to come back in 3 months. She was doing much better, and at a 6-month appointment, we re-administered the mini cog, and she scored 3 out of 3. And we helped her to identify a support person through her extended family.
A question, Dr. Segal.
Yeah.
So in that situation, do you keep the mild cognitive impairment diagnosis there, or do you remove it?
I removed it.
Okay, all right.
I removed it. Yeah. And actually the way I assessed her, the way I coded for her was suspected depression with mild cognitive changes related to mood disorder.
Okay, I see.
Mm-hmm. Yeah. And then once her depression lifted through medication, therapy, socialization, we said depression resolve.
Thank you.
Mhm. So in regard to management, again, really important to identify reversible causes if you can. In that lady's situation, her depression was causing her cognitive issue. We treated it, she got better. We, of course, want to optimize blood pressure, blood sugars, if appropriate for patients. Think about how to support someone without medications. So, really keeping people active, engaged, socializing them, exercise, treat any current disorders, so sleep and depression. So lots of information now coming out about how sleep impacts cognition and mood, and sleep apnea is such a a rich condition that can impact so many body systems. So we really do look out for that. And then, of course, treatment and supportive care if needed. Now, I realize that there are so many challenges when assessing cognition in a very busy clinical practice. So I do encourage everyone to use tools to their advantage. So if you do, we're on an Epic EHR, and we have developed some pretty fancy templates to use when assessing cognition. We don't hesitate to bring someone back for an appointment in a month or 2 weeks or whenever we can manage it, to simply talk about cognitive issues in patients, so that we're not burdened by other primary care issues that might need to be addressed. Memory changes, for the most part, are not acute. They're, especially when you're looking at dementia or neurodegenerative disorders. So you don't have to bring the patient back the next day to screen them. You've got time. These are changes people are living with over time, and you're simply giving them an opportunity to really discuss and have this looked at. And so if you can't get them in that day, that week, it's okay. You can get them in in a timely manner to fully assess. And sometimes we assess over multiple visits. So, it might be that you bring them in and you take a history, and the next time you do a really comprehensive neuro exam, and maybe, on the third time you disclose the diagnosis. So while it would be great to be able to do this all in one day, I'm realistic in that it probably won't happen. And it definitely doesn't happen in my own clinic. So when I do screen someone and then bring them back for further assessment, if their screen is positive, I then have to think about how I'm going to present a diagnosis. And even if I don't give the diagnosis a name like Alzheimer's disease or FTD, I'm still presenting the diagnosis of cognitive changes or cognitive decline. And so just a few things that I think about when I do disclose the diagnosis is it's really important to build time into the appointment. So maybe you're bringing that person back simply to disclose the information or to review the information that you found. And you can do this over separate appointments. We now have the opportunity to bill for time, and billing for time might mean that you turn that appointment into a family meeting where you bring a couple people back, and for 15 minutes or 20 minutes, you simply discuss the findings. And that's really all that the appointment is about. We do try to use compassionate communication. And the one tool that I rely on heavily, there are lots of frameworks for how to deliver bad news or break bad news, but personally, I like the warning shot best. The warning shot is simply making a statement before delivering the bad news so that the individual can sort of ready and steady themselves to hear what you have to say. It's important to be familiar with resources and then set expectations. So resources might be reaching out to the Alzheimer's Association, the Alzheimer's OC, your social worker, adult day health, community-based resources, and we'll have presentations to guide you through that. And then to set expectations. So to really help people understand that their life hasn't changed dramatically from the moment you said the diagnosis, to 5 minutes prior. You've simply given what they're experiencing a name, and that you're there to walk the walk with them as they progress through their journey with that illness. So it's really important to just ready yourself for that kind of an appointment. And we'll have a presentation really focused on, delivering this kind of information and how to ready yourself for that. In terms of follow-up for these patients, so just something to think about. So follow-up for memory, generally I recommend follow-up appointments 3 to 6 months at 3 to 6 month intervals or sooner if needed. So if they're starting a medication or having behavior changes. At each visit, we like to review the history and particularly the function and behavior. If there have been any changes in medications or medical conditions, and then maybe repeat testing every 3 to 6 months. We review safety and then of course provide resources as needed. So I realize that this has been these last 40 minutes have been extraordinarily intense. I've gone through a lot of information. And I'd like to stop here and open it up for questions if you have any. There's a lot of information here. And just know that in the coming sessions, we'll be talking about medication management, behavior management, resources, disclosing the diagnosis, and cultural considerations. So I'll stop there and open it up to questions.
Thank you, Dr. Sagel, for your wonderful presentation. We actually do have 2 questions in the chat. So the
Sure.
first question is, do you need certification to administer the MOCA?
You stop my share. Give me 1 second.
You're fine.
Do you need certification? So I am not certified to administer the MOCA, and I certainly do administer it. I am very careful. I do have instructions that I use to administer from the instructions just as they ask me to. And I think the clinicians in my office, we have 10 geriatric providers. We are none of us are certified, but we do regularly use the MOCA.
Perfect. Thank you. The second question is, with the first patient, did you diagnose her or refer her to a neurologist?
Great question. It's a great question. I diagnosed her myself. I did not refer her to a neurologist. As I alluded to before, so we rarely refer to neurology for the diagnosis of cognitive impairment, unless the patient is very young, has rapidly progressing cognitive changes, has some sort of abnormality on physical examination. So maybe they are showing features of Parkinsonism. Maybe they have some ocular changes, so eye movement that is abnormal. And if there's something very unusual in the presentation, I will refer to neurology to help me determine the diagnosis. And in those patients who I am referring, those are people that are pretty early on in the disease course. So as you know, as dementia progresses, whether it's vascular or Alzheimer's, toward the more moderate, severe stages of the condition, dementias tend to sort of start to look similar, and it's much more challenging to tease apart the nuances. And so really for early stage disease, for atypical presentations, but for patients with a slowly progressive decline in cognition over time that is primarily memory, with no findings on a neuro exam, no lab abnormalities, I'm pretty confident in making that diagnosis. And even if I don't right away call it Alzheimer's disease, maybe I just call it dementia, or maybe I just call it cognitive impairment or cognitive decline. Over time, when I see that patient again in 3 months or 6 months or a year, that decline and those changes are going to become much more evident to me. And then I'll be more confident in calling it Alzheimer's or another kind of dementia. The other thing to consider, because I know it can be nerve-wracking to say to somebody, well, you have Alzheimer's disease, or you have, this specific kind of condition. The only way to truly diagnose AD is through a brain biopsy, right? I mean, so these are all presumptive diagnoses of conditions that we are using our clinical skill, our history, our physical exam to call something. So really, these are presumptive diagnoses, and And you can make them over time. You can follow the patient over time and see how their disease changes. And hopefully, right, for a few of these folks who may have severe hypothyroidism or vitamin deficiency, maybe they're going to get better, right?
Perfect. Thank you. Regina, I believe you have your hand raised, so please go ahead.
Hi. I think doctor answered my question, but I do have a patient that I did slums 3 days ago, and the score was it was 17 3 weeks ago. It went up to 19, so it's still under the dementia, but he's only 46 years old. The my I'm contemplating between him having he's having depression because of medical condition, like with chronic pain, and at the other hand, so he would say those he would respond to like, I don't know. I do know when I went in school, when you always say like, I don't know, it's more about depression, right? As compared to you're trying your best to answer those questions, and that's more of the dementia side. Now, for this patient that I have, he both exhibits the I don't know and trying to answer those questions. Now, it's very, very difficult to tell him about the scores. I did mention to him about that dementia. Maybe my next question, because it was answered already. When should I refer him to neurology? Is it already okay to refer him to neurology? Because he's now on antidepressant medication. He's on antipsychotic medication because he's been hearing voices throughout his lifetime without even admitting it. Now he's admitting it. Should it be a neurologist that should make the final diagnosis with dementia, or it can be coming from me?
So obviously that's a very complicated situation, right? So this is a young individual in his 40s who has a lifelong, and I don't know, this is my interpretation of what you've said, who has a lifelong history of a severe mental health condition with hallucinations, who's now scoring low on a screening modality, right? So a screening test is a screening test, right? It's just one piece of information that you have to assess his cognition, right? But there are all these other things, this history, this mental health issue, right? His medications, this depression on top of, I don't know if this is, a schizophrenia or something else, bipolar, right? So the number on the slums, I'm not impressed by that. I don't even know how to interpret that based on everything else that's happening with him, right? So I do think he needs to have his mental health issues adequately treated. So I think if he's not under the care of a psychiatrist, I would probably refer to a psychiatrist to get that assessed, because really what you want to understand is, is he depressed, and can you treat it so that he is less depressed? Or
well, he's actually right now he's on psychiatry. So I do work for the psychiatry. So he's referred to psychiatry. Most likely his depression is coming from the medical condition. It's really based upon his disability. He used to be a postman, he was working very well, really do. And then it started with chronic pain. So there's a comorbidity of pain and hypertension. But as I go through with his appointments, every time we see appointments, he's getting more and more worse when it comes to his cognition. I didn't even start him with the antipsychotic, which can cause some cognitive decline. So it's more of an SNRI, like duloxetine, which I don't think really affects cognition. So right now, it's showing. It's more obvious that he's showing more of cognitive impairment. That is just really, with a comorbid of anxiety and depression.
Yeah. I think the way I would approach that patient is I would make sure that, the mental health issues are adequately addressed, regardless of what the depression is coming from. And I would, have him under the care of psychiatry. And then in terms of cognition, I think since he is young, if you're looking for a definitive, I don't know that neurology is I don't know that this is necessarily a neurodegenerative condition.
Mhm.
but you could certainly send to neurology. And in this case, you know, maybe it's appropriate for brain imaging as well, since the
Yeah.
patient's so young and this is an atypical
That's
situation.
thank you so much.
Yeah.
So I know we're out of time, but we do have 2 more questions. So the next question is, what do you do for patients who do not have a support system?
That's a great question. And I am finding that more and more of my patients lack a support system. They've either outlived their dependents and all of their family members, or they have chosen through lifestyle choices to not engage with others. And it is a challenge over time. So obviously I like to bring it up. When I first meet a patient, I like to inquire about their social support. If there is a lack of social support, we start to address that right away, slowly trying to understand the patient's perspective. And then over appointments, are there extended relatives, are there friends out there that they would be comfortable reaching out to? And if they are, we certainly encourage that. I recently had to advise a patient to seek counsel with an elder law attorney to set up a private fiduciary because she absolutely has no one and needed legal assistance in that matter. So we definitely encourage, and then we reach out to our legal partners if we need to.
Thank you. And then last question, does the diagnosis of cognitive impairment dementia on file affect the patient in his or her legal capacity? For example, will you still accept their answers to your questions or their decisions?
That is a great question. You can have mild dementia and have the ability to make decisions for yourself. So capacity for decision-making is a whole separate issue. It's very complicated, and a patient who has mild dementia can still tell me that they do or do not want to have surgery, that they do or do not want to start a medication. It's just very individual and it's very case by case, but there are ways to assess decision-making capacity. And we will definitely be discussing that in a subsequent session.
Perfect. Thank you. Before we go,